Hello everybody, so today I'll be talking about the auscultation of heart sounds. My name is Antonio Piximarian and I hope you learned something today. So for our introduction, the auscultation of the heart requires excellent hearing and the ability to distinguish subtle differences in pitch and timing. High-pitched sounds are best heard with the diaphragm of the stethoscope, low-pitched sounds are best heard with the bell. Very little pressure should be exerted when using the bell, as excessive pressure converts the underlying skin into a diaphragm and eliminates very low-pitched sounds. Major auscultatory findings include the heart sounds, murmurs, or rubs. Heart sounds are brief, transient sounds produced by the valve opening and closing. Murmurs are produced by blood flow turbulence and are more prolonged than heart sounds. They may be diastolic, systolic, or continuous. Rubs are high-pitched, scratchy sounds, often with two or three separate components, which may vary according to body position. Murmurs are graded by intensity and are usually described by their location and when they occur within the cardiac cycle. During tachycardia, rubs may be almost continuous. So, a clinician usually focuses attention sequentially on each phase of the cardiac cycle, noting each heart sound and murmur, intensity, pitch, duration, and timing of the sounds, and the intervals between them are usually analyzed, which then provides an accurate diagnosis. Now let's go to the systolic heart sounds. Systolic sounds include your first heart sound or S1 and clicks. S1 and the second heart sound or S2, which is a diastolic heart sound, are the normal components of your cardiac cycle or the familiar lub-dub sound. S1 occurs just after the beginning of systole and is predominantly due to mitral closure but may also include tricuspid closure components. It is often split and has a high pitch. S1 is loud in mitral stenosis. It may be soft or absent in mitral regurgitation due to valve leaflet sclerosis and rigidity, but is often distinctly heard in mitral regurgitation due to myxomatous degeneration of the mitral apparatus or due to ventricular myocardial abnormality. While clicks, on the other hand, occur only during systole. They are distinguished from S1 and S2 by their higher pitch and briefer duration. Some clicks occur at different times during systole as hemodynamics change. Clicks may be single or multiple. Clicks in congenital aortic stenosis or pulmonic stenosis are thought to result from abnormal ventricular wall tension. These clicks occur early in systole, very near to S1, and are not affected by hemodynamic changes. Similar clicks occur in severe pulmonary hypertension. Clicks in mitral valve prolapse or tricuspid valve prolapse, typically occurring in mid to late systole, are thought to result from abnormal tension on redundant and elongated chordae tendineae or valve leaflets. Clicks due to myxomatous degeneration of valves may occur anytime during systole but move toward S1 during maneuvers that transiently decrease ventricular filling volume, such as standing or the Valsalva maneuver. If ventricular filling volume is increased, or usually by lying supine, clicks move toward S2, particularly in mitral valve prolapse. For unknown reasons, characteristics of the clicks may vary greatly between examinations and clicks may come and go. So now I'll be playing the different systolic heart sounds. So normal S1, S2 sounds, split first heart sound, pulmonary ejection click, and your split second heart sound.
In, out, in, out, in.
Now let's go to the diastolic heart sounds, which include the following: your second, third, and fourth heart sounds are S2, S3, and S4 respectively, your diastolic knocks, and your mitral valve sounds. Unlike systolic sounds, diastolic sounds are low-pitched, usually softer in intensity and longer in duration. Except for S2, these sounds are usually abnormal in adults, although an S3 may be physiologic up to the age of 40 and during pregnancy. S2 occurs at the beginning of diastole due to aortic and pulmonic valve closure. Aortic valve closure, A2, normally precedes pulmonic valve closure, or P2, unless the former is late or the latter is early. Aortic valve closure is late in left bundle branch block or aortic stenosis. Pulmonic valve closure is early in some forms of pre-excitation phenomena. Delayed pulmonic valve closure may result from increased blood flow through the right ventricle, for example in atrial septal defect of the common secondum variety, or complete right bundle branch block. Increased right ventricular flow in atrial septal defect also abolishes the normal respiratory variation in aortic and pulmonic valve closure, producing a fixed split S2. Left to right shunts with normal right ventricular volume flow, for example in membranous ventricle septal defects, do not cause fixed splitting. A single S2 may occur when the aortic valve is regurgitant, severely stenotic, or atretic in truncus arteriosus where there is a common valve. S3 occurs in early diastole when the ventricle is dilated and non-compliant. It occurs during passive diastolic ventricular filling and usually indicates serious ventricular dysfunction in adults. In children, it can be normal, sometimes persisting even to age 40. S3 may also be normal during pregnancy. Right ventricular S3 is heard best, sometimes only, during inspiration with the patient supine. Left ventricular S3 is best heard during expiration because the heart is nearer the chest wall with the patient in the left lateral decubitus position or when the patient is lying on his left side. S4 is produced by augmented ventricular filling caused by atrial contraction near the end of diastole. It is similar to S3 and heard best or only with the bell of the stethoscope. During inspiration, right ventricular S4 increases and left ventricular S4 decreases. S4 is heard much more often than S3 and indicates a lesser degree of ventricular dysfunction, usually diastolic. S4 is absent in atrial fibrillation because the atria do not contract, but is almost always present in active myocardial ischemia or soon after myocardial infarction. S3, with or without S4, is usual in significant systolic left ventricular dysfunction, while S4 without S3 is usual in diastolic left ventricular dysfunction. A summation gallop occurs when S3 and S4 are present in a patient with tachycardia, which shortens diastole so that the two sounds merge. Loud S3 and S4 may be palpable at the apex when the patient is in the left lateral decubitus position. A diastolic knock occurs at the same time as S3 in early diastole. It is not accompanied by S4 and is a louder thudding sound which indicates abrupt arrest of ventricular filling by a non-compliant constricting pericardium. An opening snap may occur in early diastole in mitral stenosis or, rarely, in tricuspid stenosis. Mitral opening snap is very high-pitched, brief, and heard best with the diaphragm of the stethoscope. The more severe the mitral stenosis is, the closer the opening snap is to the pulmonic component of S2. Intensity is related to the compliance of the valve leaflets. The snap sounds loud when the leaflets remain elastic, but it gradually softens and ultimately disappears as sclerosis, fibrosis, and calcification of the valve develop. Mitral opening snap, although sometimes heard at the apex is often heard best or only at the lower left sternal border. Split second heart sound in left bundle branch block.
Out. In. Out. In. Out. In.
Split second heart sound in right bundle branch block.
In. Out. In.
Split second heart sound with atrial septal defect.
Out. In.
Third heart sound. Fourth heart sound. Summation gallop. Diastolic knock. And mitral valve opening snap. Next is the approach to murmurs. Timing of the murmur in the cardiac cycle correlates with the cause. Auscultatory findings correlate with specific heart valve disorders. Various maneuvers such as inspiration, hand grips, squatting, valsalva can modify cardiac physiology slightly, making differentiation of causes of heart murmur possible. So first is systolic murmurs. This may be normal or abnormal. They may be early, mid, or late systolic, or holosystolic or pansystolic. Systolic murmurs may be divided into ejection, regurgitant, and shunt murmurs. Ejection murmurs are due to turbulent forward flow through narrowed or irregular valves or outflow tracts, usually due to aortic stenosis or pulmonic stenosis. They are typically mid-systolic and have a crescendo diminuendo character that usually becomes louder and longer as flow becomes more obstructed. The greater the stenosis and turbulence, the longer the crescendo phase and the shorter the diminuendo phase. Systolic ejection murmurs may occur without hemodynamically significant outflow tract obstruction and thus do not necessarily indicate a disorder. In normal infants and children, flow is often mildly turbulent, producing soft ejection murmurs. Older patients often have ejection murmurs due to valve and vessel sclerosis. During pregnancy, many women have soft ejection murmurs at the second intercostal space to the left or right of the sternum. The murmurs occur because a physiologic increase in blood volume and cardiac output increases flow velocity through normal structures. The murmurs may be greatly exaggerated if severe anemia complicates the pregnancy. These murmurs are distinct from the venous hum, sometimes caused by engorged breast vessels during pregnancy. Regurgitant murmurs represent retrograde or abnormal flow into chambers that are at lower resistance, usually due to mitral regurgitation, tricuspid regurgitation, or ventricular septal defects. They are typically holosystolic and tend to be louder with high velocity, low volume regurgitation or shunts, and softer with high volume regurgitation or shunts. Late systolic murmurs, which may or may not be preceded by a click, are typical of mitral valve prolapse or papillary muscle dysfunction. Various maneuvers are usually required for more accurate diagnosis of timing and type of murmur. Shunt murmurs, on the other hand, may originate at the site of the shunt or result from altered hemodynamics remote from the shunt. So, for example, pulmonic systolic flow murmur due to an atrial septal defect with left to right shunt. Now let's play an aortic stenosis murmur. Pulmonic stenosis murmur.
In. Out. In. Out.
Mitral regurgitation murmur. Ventricular septal defect murmur. Now let's go to the diastolic murmurs. Diastolic murmurs are always abnormal. Most are early or mid-diastolic, but they may be late diastolic or pre-systolic. Early diastolic murmurs are typically due to aortic regurgitation or pulmonic regurgitation. Mid-diastolic or early to mid-diastolic murmurs are typically due to mitral stenosis or tricuspid stenosis. A late diastolic murmur may be due to rheumatic mitral stenosis in a patient in sinus rhythm. A mitral or tricuspid murmur due to an atrial tumor or thrombus may be evanescent and may vary with position and from one examination to the next because the position of the intercardiac mass changes. So systolic murmurs may be normal or abnormal, but diastolic murmurs are always abnormal. Last type of murmur are your continuous murmurs, which occur throughout the cardiac cycle. They are always abnormal, indicating a constant shunt flow throughout systole and diastole. They may be due to various cardiac defects. Some defects produce a thrill. Many are associated with signs of right ventricular hypertrophy and left ventricular hypertrophy. As pulmonary artery resistance increases in shunt lesions, the diastolic component gradually decreases. When pulmonary and systemic resistance equalize, the murmur may disappear. Patent ductus arteriosus murmurs are loudest in the second intercostal space just below the medial end of the left clavicle. Aortopulmonary window murmurs are central and heard at the third intercostal space level. Murmurs of systemic arteriovenous fistulas are best heard directly over the lesion. Those of pulmonic arteriovenous fistulas and pulmonary artery branch stenosis are more diffuse and heard throughout the chest. When circulation is increased, as occurs during pregnancy, anemia, and hyperthyroidism, a continuous venous hum is often heard in the right supraclavicular fossa. This venous hum also occurs normally in children. The sound generated by increased flow in a dilated internal mammary artery may be mistaken for a continuous cardiac murmur. This is what the patent ductus arteriosus murmur sounds like. Next is your pericardial friction rub. This is caused by movement of inflammatory adhesions between visceral and parietal pericardial layers. It is a high-pitched or squeaking sound. It may be systolic, diastolic, and systolic or triphasic, which means when the atrial contraction accentuates the diastolic component during late diastole. The rub sounds like pieces of leather squeaking as they are rubbed together. Rubs are best heard with the patient leaning forward or on hands and knees with breath held in expiration. So this is what a pericardial friction rub sounds like. So when it comes to auscultation, there is something that we have to remember, and this is where exactly are we supposed to auscultate. So a good mnemonic to remember the spots is apartment M 2245. The letters indicate the valve to be auscultated, while the numbers indicate the intercostal space upon which these valves are located. So A for aortic, P for pulmonary, T for tricuspid, and M for mitral. Your aortic valve is found in the second intercostal space at the right sternal edge. Your pulmonary valve is found in the second intercostal space at the left sternal edge. Your tricuspid valve is found in the fourth intercostal space at the lower left sternal edge, while your mitral valve is found at the fifth intercostal space in the mid-clavicular line. So how do we perform auscultation of heart sounds? So a systematic routine will ensure that you remember all the steps whilst giving you several chances to listen to each valve area. This routine should avoid excess repetition, while each step should build upon the information gathered by the previous steps. As always, the first thing to do when you are to auscultate a person is to introduce yourself to them and ask them for their permission to perform the procedure. Explain to them where you will be placing the diaphragm and the bell of your stethoscope and where you will be palpating. So when we are doing auscultation of the heart sounds, we must first palpate the carotid pulse to determine the first heart sound. After that, we auscultate upwards through the valves using the diaphragm of the stethoscope while continuing to palpate the carotid pulse. So apartment M2245, that is going, apartment M is going, starts at the top and then to the bottom. So when we auscultate, since we have to auscultate upwards, we start at the fifth intercostal space in the mid-clavicular line or your mitral valve, followed by your tricuspid valve, pulmonary valve, and then finally your aortic valve. After you finish with the aortic valve, you have to repeat the auscultation across the four valves with the bell of the stethoscope. So, accentuation maneuvers. After you auscultate the carotid artery using the diaphragm of the stethoscope while the patient holds their breath to listen for radiation of an ejection systolic murmur caused by aortic stenosis. Sit the patient forward and auscultate over the aortic area with the diaphragm of the stethoscope during expiration to listen for an early diastolic murmur caused by aortic regurgitation. Next, roll the patient onto their left side and listen over the mitral area with the diaphragm of the stethoscope during expiration to listen for a pansystolic murmur caused by mitral regurgitation. Continue to auscultate into the axilla to identify radiation of this murmur. With the patient still on their left side, listen again over the mitral area using the bell of the stethoscope during expiration for a mid-diastolic murmur caused by mitral stenosis. So bell versus diaphragm. The bell of the stethoscope is more effective at detecting low frequency sounds, including the mid-diastolic murmur of mitral stenosis, while the diaphragm is more effective at detecting high frequency sounds, including the ejection systolic murmur of aortic stenosis, the early diastolic murmur of aortic regurgitation, and the pansystolic murmur of mitral regurgitation. Here's a quick video on how to perform auscultation of the heart.
Hi there, my name's Andrew. I'm one of the final year medical students. Could I just check your name and date of birth, please?
Sure, it's James Alexander, 13th of December 1989.
Nice to meet you, James. Today I've been asked to examine your heart. This will involve looking from the end of the bed, feeling a pulse in your neck and your wrist, and also listening to the heart as well. Would that be okay?
That's fine.
Have you any pain anywhere before we begin?
No.
Have you any questions?
No.
James, I'm now going to listen to your chest, and I'll be feeling the pulse in your neck at the same time, okay? And sit forward for me. Deep breath in and out. Hold it there. And breathe normally. And roll onto your left hand side for me. Deep breath in and out. And hold it there. And breathe normally. James, I'm now going to...
And that concludes my presentation regarding auscultation of heart sounds. I hope you have learned something today, and I'll see you in the next one. Bye-bye.